Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. And thank you for joining me today on this first of a series of special episodes looking at policies impacting connected health technologies in healthcare. Joining me for this monthly series as my co-host is Morgan Reed. Good morning, Morgan.
Good morning, Jim. It's always good to be here with you.
Morgan is the president of the App Association and is also heavily involved with Connected Health Initiative. Connected Health Initiative, or CHI, is a coalition of industry stakeholders and partners working to clarify outdated health regulations, incentivize the use of connected health technologies, and ensure an environment in which patients and consumers can see improvement in their health. Morgan, I'm really excited to talk today and kick off our monthly discussions.
Absolutely. This is a topic that I think we're both pretty passionate about, and we can kind of see the direction that we're going and trying to figure out how do we get there.
The first thing I'd like to ask you, Morgan, is if you could give us a brief introduction to the Connected Health Initiative, why it was developed, what's it accomplishing, and the aspects of collaboration that it's built upon.
Like anything, you build something because you see a problem or a need. Just like you're building a shed to cover up your stuff. In this case, what we were looking at is a situation where practically every man, woman, and child walking around the world today, and especially in America, had what amounted to a supercomputer in their pocket, a device that could help them do all sorts of things, and yet our healthcare industry was still dealing with fax machines. So at the advent of the smartphone, a bunch of us got together, some of the biggest leaders in the technology industry, the biggest players in the healthcare industry, and we said, how do we kind of come together around these important and needed tools to get to where we know we have to get to, which is better patient outcomes and, frankly, a better work environment for our caregivers. I'm really honored and humbled to say that the participants right off the bat in CHI were all your tech brand names, your Apples and your Microsofts and folks like that. But more importantly, it was also your healthcare folks from your American Medical Association, American Heart Association, the Cancer Society folks and others, and leading academic medical centers. We all came together and looked at it and said, we have a problem to solve that technology is going to play a role in, and how are we going to do it? Because I think your listeners, more than anyone else, can kind of see the fact that by, in very short order, we are going to have too many people with chronic conditions that need treatment and not enough doctors, nurses, and care providers to meet that goal.
What's your role, Morgan, at CHI?
Well, right now I'm serving as the executive director, which means I get told what to do by all of the players, but I help to coalesce everyone around some single ideas. And one of the things that we spend a lot of time looking at is, what are the problems that need solving right now? What are the problems that are going to need solving in the future? And what are the ways that we can eliminate some of the barriers that exist either through regulation or through practice that make it harder for the patient to get the care they need and for the caregiver, that physician on the front line, to give them without becoming a doctor of the keyboard and still staying a doctor of a patient. For me, a lot of it comes down to harnessing and focusing around the specific areas of problems that we're always trying to solve. We look at it through three questions, right? There's three questions you're asking about anything. The first is, does it work? You might have heard the term efficacy gets thrown around a lot in the healthcare industry, but that's really the question. Does it work? Does it work for the care provider? Does it work for the patient? Do we have data to back it up? Do we have studies that support it? How do we show that the technology that's being provided works? The second part that we always have to solve is, what are the risks to those receiving care and delivering care? If you think of it this way, we all know that one of the worst possible outcomes is obviously a loss of life for a patient. But also, we have to think about, what do we do about things like, how are we protecting your personal health information? How are we making sure that the hospital isn't accidentally violating their requirements under Hipaa because some app that they're using is leaking data, and they have a business associate or relationship with that app. So you've got the obvious things, which is the harm to patient, but you've also got the risks that are posed to the institutions, to the doctor. If the product isn't right, does it hurt the patient? So you've got to deal with, does it work? And then you've got to deal with the other thing is, what do we do about the risks that are associated? And then finally, and this is something that you, Jim, and I have talked about before, drives healthcare, which is, what's the reimbursement for it? Our entire fee-for-service medicine world works off the idea that you bring in your broken car and the mechanic fixes it. Correct. And the mechanic only gets paid when they fix it. But part of that, it creates problems because sometimes what you need to do with a patient, especially if they have a chronic condition, is monitor them over time, work with them to improve, reward them for doing the right thing, for finishing their medication, taking their steps, doing whatever treatment it is you recommend. And for a fee-for-service medicine world, it's really hard to build a program that appropriately reimburses for the kind of work that means the doctor does less, not more. So really, those are the three things that we spend most of our time thinking about. Does it work? What are the risks? And how does reimbursement work? And so that's really the framework that we use for all of our discussion around digital medicine.
One thing that we found, Morgan, in a healthcare system, kind of the third one that you mentioned here around reimbursement, because if something is going to be reimbursed, it's going to be done if it's reimbursable.
Exactly. Yep.
And so, an example might be when we had it's not, I don't want to talk about the past tense, but the COVID pandemic. Emergency measures were declared health emergencies, and all of a sudden telehealth visits were reimbursed at a level that was the same as an in-person visit. And I don't know if that's gone away, but it's going to go away unless something changes. And so it seems like good technology, but if that reimburse is not maintained or continued in some way, then that technology is not going to be employed. And so what does CHI do? Do you lobby? Do you write policy? What do you do?
Right. So if you think of that as the horror of COVID had one silver lining, and that was it finally put answers to this question of, does it work? Is it necessary? And what you saw throughout the world, and especially in the United States, was this idea that when we had, and you correctly identified it, we essentially had a public health emergency declaration that allowed reimbursement to flow for things like telemedicine visits with real-time voice and video, for remote patient monitoring, a better use of codes like 99041 and other codes like that really allow for patients and doctors to engage without necessarily having to sit and read old magazines for 2 hours before you walk into the doctor's office and get a check on something that you could have done at home. So it really showed that it worked. And states like Virginia, where I'm currently residing, they saw it at the state level was incredibly successful. But Jim, you hit the point on the head. We all want the pandemic to go away, but what we don't want is for the sweeping changes to regulation that allowed us to embrace new technology to go away with it. Because if we do, as you pointed out, the reimbursement that currently allows it to flourish goes away too. And some of these regulations that we spend a lot of our time working on CHI are just frankly silly. There's an obscure code that has held up a lot of telemedicine and remote patient monitoring for decades that has to do with the fact that the reimbursement at the Centers for Medicare and Medicaid, as you know them, Medicare and Medicaid is basically 1/3 of our entire healthcare system. $1 trillion a year or more of money gets reimbursed through that system. They couldn't reimburse unless the technology that was supported was a live voice video provided at essentially a fully qualified health center inside of a region that was known as a HIPAA. It had all of these insane requirements. It basically said you had to be in a rural area, you had to be a certain distance away from any doctor, and then you had to go to some place to get your telemedicine visit. Because it was envisioned back in the day where you'd drive to a clinic that had some fancy equipment, and then you'd be on a video camera with a doctor. Well, right now, all of us can reach into our pocket and pull out a device that has a better camera, that has better sensors, and has a better system than a lot of those 1990s telemedicine centers that existed. So the law was built around one style of technology. but we now all carry that technology with us. Yet reimbursement was still behind the times. And so with what's known as, 1834M, you couldn't get paid. Doctors couldn't get paid. And as you said earlier, if there's no reimbursement, then doctors simply aren't going to be able to afford to do the kinds of visits we need. COVID broke that. It allowed that reimbursement to happen. And what you saw was patients getting care they needed much faster, much cleaner, and frankly, giving the doctors insights into the patients over time rather than 8 months after the incident happened when the guy rolls in and gets a physical and he's like, oh yeah, doctor, by the way, this happened to me 8 months ago. Can you take a look at it? That was terrible then. This is a better system. But those are the kinds of regulations that Connected Health Initiative, our partners throughout both the medical industry and the medical institutions and the technology industry are really trying to push back on. How do we fix that? How do we use the public health emergency in a way to show the effectiveness of telemedicine and remote patient monitoring? And then how do we convince what's the right word?
Well, it's the people who are writing the regulations.
Well, yeah. That's what's interesting, Jim. It's not the people who write the regulations. It's often because government institutions are like a boulder rolling downhill. Mm-hmm. They take on momentum, they take on energy of their own, and standing in front of that boulder takes an enormous amount of strength. Because when you talk to the folks at Center for Medicare and Medicaid, you talk to the people who do reimbursement, and you say, "This is insane. Why won't you reimburse for this?" They'll say, "Well, we didn't reimburse for it before. And if I reimburse for it now, then I might get in trouble. And I don't want to get in trouble, so I'm going to tell you no. And yes, I can tell you over a cup of coffee, but that's crazy. But right now, I don't want to lose my job, so I'm not going to say yes." And so even getting people who understand what's going on to take that brave step and stand in front of the boulder inside of government, there's no incentive for them to do so. And frankly, a ton of reasons not to. So a big part of what we have to do is sit down with those folks over coffee and sit down with the legislators and the regulators and the new secretary of HHS, both for this administration and the past, and say, this is the time to be brave. This is the time to support the American people and the healthcare workers and give them the reimbursement they need to provide the technology that's in everyone's pocket and get it reimbursed for.
Gotcha. Well, connected health technology, as you've explained it, Morgan, it seems to really be an intersection of the patient, technology, and public policy. Let's talk about public policy for just a minute. It seems like this technology is only good if you get it in the hands of the people who need it. And so how do we remember and deal with the concept of inequity of healthcare in the U.S.? How do we make sure the technology is available?
Well, that's a great point. So broadband deployment is obviously something that we need everywhere. We've all lived through kids going to school virtually, which sucked. That's I know I shouldn't use those terms, but let's face it, it sucked. But it had to be done. And similarly, what we learned was without that vital technology, you have a problem. But I think within healthcare institutions, the fact that we're still fighting against the fax machine is really telling. On the inequity side, here was something that we found that was most fascinating. You don't normally use this word in the name of this state in connection with being number one at many things. But one of the number one states in telemedicine is actually the state of Mississippi. And the reason is there is an enormous underserved Black population in what's known as the Mississippi Delta. And unfortunately, the Mississippi Delta doesn't have enough care providers, but it doesn't count as rural under what I was talking about before, this idea of this rural area that you can get an exception for providing telemedicine services. So the state of Mississippi, realizing they didn't have enough care providers in an area where they had a population that was underserved and frankly, importantly, had a real ongoing issue with type 2 diabetes and obesity, the state was hemorrhaging money serving these people because getting somebody into an ambulance and driving them 2 hours to see a caregiver and then driving them back was economically horrible, but also from the human perspective, an absolute miserable experience. So the state of Mississippi under its academic medical center known as UMMC built out an incredible telemedicine and remote patient monitoring service where they have provided tablets into folks with type 2 diabetes, to really help engage with them and nudge them as they monitor their information. And I mean, it's a simple thing, like Mrs. Jones pricks her finger in the morning, takes her blood sugar, taps it in, it's recorded, and a nurse sees that it's high. She's got a dashboard. That nurse then reaches out to Mrs. Jones and says, Miss Jones, your numbers are kind of high. What's going on? And Mrs. Jones says, well, this last weekend we had a family reunion and probably hit the pecan pie a little too hard. Okay. So we're there in the moment, in that incident, and you say, hey, talk to me about your family reunion. How was it? Did you have a good time? I'm going to engage with you as a person. And then say, okay, so let's get control of it this week. Here's some things that we can do. Let's check it again in another day. And that patient feels heard. They felt part of something. And frankly, the state of Mississippi now saved a lot of money by not having Mrs. Jones go blind or having to deal with diabetic foot ulcers or any of the other numbers of things that happen to someone when they do it. So they're engaging with the patient earlier, using remote patient monitoring, and so long as they have the broadband and the equipment to provide it, they're doing the kind of medicine that everybody wants to do, which is get their patients healthy and keep them healthy. And that's a big part of ending inequity, which is connecting to people where they are, engaging with them as humans and not numbers, and finding a way to make it real for them and a lived experience that they can use the technology going forward. But unfortunately, Jim, the state of Mississippi has to reimburse that out of the state budget, and they're still fighting with the federal government to get more of it covered by the federal system as well. So back to your reimbursement point, they're just having to eat that instead of finding a way for it to be supported by the larger system.
Well, the scenario you just outlined, Morgan, once you have that broadband internet in rural areas, the cost of a tablet is, hardly anything.
Nothing. I mean, think about the cost of a doctor's visit. Think about the cost of an emergency room visit.
Well,
a helicopter will cost them $10,000. Think of how many tablets you can provide for $10,000 for a hospital visit. I mean, right. for a helicopter ride.
And during COVID, when all the students went online, most school systems gave every student a laptop, absolutely. Not just a tablet, but a laptop.
Yep, absolutely.
So it was found. Well, why is connected technology so challenging in health? What's the big challenge? Is it just hard to change the status quo, or
Yeah, I'd say there's kind of three things. One of which is status quo. The second, which is I would put it on the headline of data. In other words, how do we show that it's effective? How do we fix things that are problematic? And then a big part of it is when we're collecting data on patients, how are we handling it? Are we keeping it private? Are we keeping it protected? And I think the part that your audience knows better than the general audience, and that is it's got to work within the existing electronic health record system. The idea that patients or nurses have to have another login and another password or something else that's on the lanyard around their neck is simply crazy. And so a part of what we at CHI are working on and working with some of the EHRs to make sure we have is interoperability. Because if I've got the data and I've overcome the inertia that's holding it all up, I've got to make it work for that care provider. And that means no extra logins, no new interfaces. It's got to be there for them in a way that they can use and turn data into actionable information. And that's part of the problem that we in the tech side haven't solved yet. But also some of it comes down to public policy. It was only last year, I guess a little more than a year ago, that the government finally came out with about an 800-page guidance document on interoperability, which was mandated under the Cures Act.
Yeah.
So, I mean, it was an 800-page tome having to do with anti-blocking and what do you do about info sharing and what kind of APIs are required. We certainly, it's taken a long time to get there, but those are the kinds of regulatory requirements that have to be part of it. So you've got Hipaa, which, look, at least I'm talking to an audience with you, Jim, that understands that Hipaa doesn't cover everything and you can't use it at your grocery store. HIPAA is not part of that. But for those of us who are inside the healthcare world and understand what it means to be a covered entity or a business associate, we know those are stringent requirements. And we know the Office of Civil Rights has no problem with suing someone or at least placing a fine on a hospital or a provider for letting patient data get out into the wild. So we know there's a hefty fine attached to that. So making sure that we on the tech side and the industry side are doing the right thing in handling the data is a big deal. And then that part is, so if we got to handle it privately and securely, but we've also got to share it with your electronic health record, how do we do that? How do you have interoperability? And how do you do it in a way that protects the patient, provides what's needed, and ultimately gets the information into the hands that need it first?
Morgan, one thing I like in what you're saying, I'm so used to 5 or 10 years we've been talking about interoperability, but you are talking, and the connected health work you're involved with is a larger scope. It's not just the interoperability of the data. It is like going that, final 50 yards to the actual patient.
Yeah, that's it in a nutshell, right? So when the HITECH Act was passed, when Hipaa was started, this idea of data portability, the idea that the patient has the right and the access to their data was critical. But from a patient perspective, you want to take it isn't though that data is preserved in amber. You want that data so that you can do something with it. You want to do it so that you are an active, engaged patient and not a passive patient. But that means that data has to be usable by the provider that you're going to. I mean, I know we all joke about Dr. Google, but there's a reason I don't do my own plumbing. I go to a plumber because I don't want to deal with some of the questions there. I hire an electrician because I don't do electricity. I know how to hang sheetrock and I know how to do woodworking, but I don't do my own electricity. In the same way, I need to take my data to a doctor to help me solve my problem. And that means I need to give it to them in a format that they can use, not on a CD or a USB stick, or hand it to them in a ream of paper that I printed out of PDFs. I need that doctor to be able to have that information and turn it from random ones and zeros into actionable information that they can use their knowledge, their 15 years of schooling and practice to make sure that we get the solution that gets me healthy fast, or if I've got a chronic condition, that I've got a treatment that I can use every day and get me as close to a perfect quality of life as I can if I'm battling through a chronic condition.
One thing that this is kind of the whole issue of healthcare data, Morgan, that really been brought home to me in the last couple of years with COVID is not only the individual healthcare delivery, but the whole concept of public health. And I think gaps in data that were received of who's been immunized, who's sick, who's positive, who died, all that stuff. And folks at the top had to make public policy decisions during the pandemic, and they had data they acted on, but it was not necessarily valid data.
Yeah, in the tech industry, we call that garbage in, garbage out.
Yeah.
If your data sucks, your answers are going to suck. And so part of what we're all working on, and we'll talk about this later, is how do we use these data sets? But I think what's important for us to remember is the technology is kind of at the intersection between the patient and their outcome. It's not the answer. It's the tool to link things up. And as you say, bad data produces bad results. So getting good data into the systems becomes critical. And I think that gets to something that we all know as patients, the difference between being passive and active, right? That's the problem when you go to your doctor once every year or every 8 months for a quick checkup. The doctor only sees how you are on that day. They don't know about the ups and downs that happened over that time. And if you've got a chronic condition, that can lead to situations where, and this happens in diabetes all the time, where a patient may on the day have great blood sugar, and they might have great blood sugar the 10 other times they've been in to see the doctor, but they've got a yo-yo happening everywhere else. And before you know it, they've got diabetic retinopathy and they've gone blind, or they've had an increase in neuropathy in their feet and they're losing their toes through ulcers and foot sores. So going from spot checking to linear data over time, good, accurate linear data over time, really, really helps the patient and the care team get the need. And I kind of want to end on one note that you're talking about gaps. We have a huge problem that we in America are not conscious about, and we don't talk enough about. And that is that in short order, we are in deep muck very soon on our healthcare for some basic numbers. So in the United States, By 2030, 2035, we'll have more than 70 million Americans over the age of 65. Of those, statistically speaking, 80% will have at least one chronic condition. Now, by 2025, in 3 short years, the AMA estimates we will already be 90,000 physicians short to meet the number of patients that we have to serve in 2025, but we've got all the boomers coming along in 2035. We will not be able to serve the number of Americans who deserve, have paid for, have earned the treatment that they need and should earn as a human being, because we simply won't have enough care. So if we don't take into consideration the ways to make technology create active patients, and so they don't have to see the doctor as often or in the same conditions, or allow one doctor to treat people throughout their state, we have no solution. Climate change is a huge issue, but this is happening in the next 10 years. Not enough doctors, too many patients, we've still got the chronic conditions. So this rush to connected health isn't about money or, somebody's going to make some money. This is about solving a dire problem within the healthcare system. And frankly, the worst part about COVID is, as you've seen, 500,000 people within the healthcare system have now quit working inside that system from burnout or you name it. And the shortages that we know that we're going to face by 2030 have only gotten worse, not better.
Well, thank you for that, Morgan. And we're drawing to the end of our session here. But I want to say our listeners can learn more about the work at Connected Health at the website connectedhi.com. To our audience, thanks for tuning in to the first of this series looking at policies impacting connected health technologies. Salute to you, Morgan, for coming on board as my co-host for this series.
I'm glad to be here, and it's a topic that we are both passionate about, and hopefully we can help find solutions on. And I look forward to our next session.
Yep, I'm looking forward to next month's episode. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.